Representative Banta.
Here in the room.
Representative Bratcher.
Here in the room.
Representative Birch. Representative Flannery.
Present, Annex Office.
Thank you. Representative Gentry.
Here in the room.
Representative Herron. Representative Huff.
Here in the room.
Representative Cook. Representative Massey.
Here in the room.
Representative McCoy.
Here.
Representative Meredith. Representative Miller.
Here.
Representative Moser. Representative Palumbo. Representative Pratt. Representative Santoro. Representative Timoney. Representative Westrom. Chairman Koenig.
Here in the room. I see Ag is let out. We have Representative Cook arriving, and I'm sure Representative Pratt will be right behind him. Few announcements. First of all, please silence your cell phones. If you're interested in testifying, please use the sign-in sheet in the back. Testimony is within the chair's discretion based on time constraints and information already presented, and no signs are permitted in the committee room. We would like to welcome our newest member, Representative Herron. Welcome. With that, we will get started, and we will start with Representative Thomas, House Bill 97. Welcome.
Thank you, Mr. Chairman. Appreciate you having me here and letting me present this important bill. Appreciate all these people coming to watch me present this.
Exactly.
This is maybe they might be here for a different reason. Mr. Chairman, this is just a very simple legislation that basically allows the ophthalmic dispensers to be able to set their fees by their own board. We've done quite a few of these. I think most of your members are familiar with them, and the ophthalmic dispensers would like to be included this time also.
Motion by Representative Huff, second by Representative Gentry. Any discussion or questions? Seeing none, please call the roll.
Representative Banta.
Yes.
Representative Bratcher.
Yes.
Representative Birch. Representative Flannery.
Aye.
Representative Gentry.
Yes.
Representative Herron.
Yes.
Representative Huff.
Yes.
Representative Cook.
Yes.
Representative Massey.
Yes.
Representative McCoy.
Yes.
Representative Meredith.
Yes, ma'am.
Representative Miller.
Yes, ma'am.
Representative Moser. Representative Palumbo. Representative Pratt.
Yes.
Representative Santoro.
Yes.
Representative Timoney. Representative Westrom. Chairman Koenig.
Yes. Motion passes. The same shall pass on the House floor. Congratulations.
Thank you, Mr. Chairman and members.
Absolutely. Next is Representative Weber, House Bill 354. Come on down and welcome to everyone. Familiar face and Ms. Fletcher. Floor is yours. Please have your guests introduce themselves.
I'm State Representative Russell Weber, 26th District.
I'm Dr. Beth Parton. I'm a family nurse
You
practitioner.
need to turn on the mic, please.
Sorry. I'm Dr. Beth Parton. I'm a family nurse practitioner.
I'm Wendy Fletcher. I'm a family nurse practitioner from Moorhead, Kentucky.
And Representative Patty Minter, a primary co-sponsor of this bill.
Chairman Koenig and members of the committee, thank you for the opportunity to present House Bill 354. Before I begin my statement, Mr. Chairman, I think we do have a committee substitute.
We have multiple motions and 1 second. Any questions on the motion? Seeing none, all in favor signify by saying aye. All opposed? We have the sub before us.
Mr. Chairman, I'm pleased to present House Bill 354 today, and I have with me Representative Patty Minter, who is the primary co-sponsor. We also have 40 other co-sponsors on this bill, and I see quite a few that are on this committee, and I want to thank you for your sponsorship of this legislation. We strongly support this legislation because of our concern that Kentuckians across the Commonwealth do not have access they need to quality health care. I know personally that advanced practice registered nurses provide the kind of health care because my family and I see a nurse practitioner for our primary care. Like all of you, I'm very concerned about the opioid epidemic in our Commonwealth. I would not be bringing this bill if I thought that there was any outcome of this legislation that would add to that problem. House Bill 354 does not increase the number of APRN prescribers of controlled substances or opioids. APRNs have been safely prescribing controlled substances since 2006, as you can see from the CASPER data that's provided in your packets. Strict limitations on prescribing amounts and refills for controlled substances were put into the statute in 2006. We are not changing any of those. What we are changing with House Bill 354 is removing barriers to health care access by removing the requirement for having a collaborative agreement for prescriptive authority for controlled substances. You'll hear that commonly referred to as the Kappa CS. After the APRN has had a Kappa CS for 4 years, and after the Kentucky Board of Nursing reviews the license status of the APRN. This review by KBN was added with legislator input to assure that the APRN's license is in good standing and that regulatory oversight continues after removing the Kappa requirement. In response to a recommendation and my working with the Speaker, we were able to add an important component that is included in the committee substitute. We add a board here that has teeth to look at those prescribers of opioids in this state, and I think this is a good addition to this bill. We'll hear people talk about the opioid epidemic and those writing prescriptions, and this is a good first start to enforcing that, finding those that are responsible for that, and then reporting those individuals to their respective boards. And I think it was a good addition to this bill, and I strongly support it. We believe that this additional oversight will give us a greater comfort level that controlled substances prescribing is being carefully monitored by the board as actions are tracked. In addition, in the committee substitute, there's language that Representative McCoy suggested to me. I looked at it, talked with the folks involved, and believe that that was a good addition to the bill, and that was added to the committee substitute as well and is before you. My goal is to make this a strong bill that helps the folks in the Commonwealth really receive the care they need. Before I turn this over to our guests here today, there's an important point that I want to make. While we have House Bill 354 before you today, and you'll be voting on this, you've actually voted on this issue twice before with the executive orders issued by the governor in March, April of 2020, and again in the special session of September 2021. We passed legislation, or we passed the executive orders and put those in place, allowing nurse practitioners to write controlled substance prescriptions from not being under the Kappa CS. There are, and folks will talk about they're wanting data and that they can quantify that by. We have 7 quarters of CASPA reporting data that indicates that there was no substantial increase in the number of controlled substance prescriptions written by APRNs. So that data is there, 7 quarters. since March of 2020, and there is no evidence to suggest that passing this legislation today will be a problem. At this point, I would like to turn the discussion over to Dr. Wendy Fletcher, President of the Kentucky Association of Nurse Practitioners and Nurse Midwives, and Dr. Beth Parton, Vice President and Legislative Chair, to present their views on the testimony.
Go ahead.
Good morning, and thank you, Chairman Koenig and committee members, for allowing me the privilege of representing over 2,000 of Kentucky's advanced practice nurses in support of House Bill 354. My name is Dr. Wendy Fletcher. I'm an APRN, a nurse practitioner in family practice for Morehead, Kentucky. I was born, raised, and educated just a few miles from the clinic I now co-own. I chose to become a nurse practitioner after watching my mother endure 4 difficult years of breast cancer treatment. Surrounded day and night by a dedicated, well-educated, and skilled nursing staff who stood by her in hospitals, infusion clinics, radiation treatment facilities, and eventually on her hospice bed, 20-year-old me, then a biology and chemistry major, had seen enough medicine firsthand to know that holistic nursing practice, not medicine, was what I wanted to do with my life. It is more than my vocation. It is my life's work, giving back to the people I love and care for in the community that I call home. I've cared for fellow Kentuckians as a family nurse practitioner for the last 23 years. I tell you this because my story as a Kentucky APRN is not so different from so many of my colleagues. We chose nursing because we care. We chose nursing because we are skilled and well educated, and many of us with terminal doctorate degrees. And like 70% of my colleagues who recently responded to a survey from our association about their practice environments in recent years, I live and or work within 50 miles of the place of my birth. Kentucky APRNs, like many of you, are literally taking care of the folks back home.
Motion on the bill?
Second.
There's going to be some folks speak in opposition. I appreciate the motion, and it will be accepted, but you can keep going.
Thank you.
I understand we're going to take about probably a half an hour total for both sides.
Thank you. I currently practice in a multidisciplinary clinic providing a full array of primary care services, including the management of opioid use disorder. With a mental health nurse practitioner and a certified drug and alcohol counselor, we provide case management and counseling services, and today we celebrate a milestone of our 7th patient in the last 18 months to hit her 1-year sobriety goal on her road to recovery. House Bill 354 will help increase access to APRN care at clinics just like mine throughout Kentucky. House Bill 354 is a strong bill, a bill with a history of vocal bipartisan support on the House floor going back many years. Our thanks to ardent supporters, both past and present, such as former floor leader Representative Bam Carney, Representatives Jerry Miller and Kevin Bratcher, Senators Paul Hornback and Julie Rocky Adams, who have carried this legislation in the past, and of course, our tireless sponsor, Representative Russell Weber, and our current co-sponsors. In its current version, House Bill 354 has 42 co-sponsors on the House floor alone. This is important legislation to improve access to care, as according to the National Health Resource and Service Administration, more than 1.4 million Kentuckians live in a designated health provider shortage area. Many of you have seen this bill in a variety of iterations over the last several years, each year bringing new challenges for nurse practitioners and nurse midwives and new compromises on our side of the table to get us to where we are today, sitting before you with a solid bill that has incorporated every suggestion of House leadership, including Speaker Osborne, Speaker Pro Tem Meade, and as recently as this week, Representative Majority Whip Chad McCoy. We've incorporated the thoughtful suggestions of Senate leadership as well, including our bill sponsor last session, Senator Adams, and President Pro Tem David Givens. Today, we bring you facts. We bring you data. We want to make this an easy vote for you because the fears and confusion presented by our opposition are not only unfair, they are misrepresentations of APRNs as perpetuators of addiction, which is woefully untrue. Let me alleviate any fears you may have heard about this bill by providing you with a few facts. House Bill 354 is not a scope of practice expansion. Prescribing controlled substances has been within our scope for 16 years. We have always been and will continue to be held accountable for our own actions under the law. You may have been told that overdose deaths have risen during the pandemic by 30%. That's fact, but not because APRNs were prescribing without a Kappa CS. According to the CDC, those overdose deaths were multifactorial, primarily due to the lack of mental health services, the lack of medication-assisted therapy services for opioid use disorders, and primarily due to illicit fentanyl and synthetic opioids, not prescription drugs. Even our own Office of Drug Control Policy has issued public warnings about illicit and synthetic fentanyl products and other street drugs. Fear: Kentucky has a drug problem. APRNs make it worse. Fact: it is well documented that Purdue Pharma and other opioid manufacturers targeted states like Vermont, West Virginia, and Kentucky due to our high populations of coal miners and manual laborers. And yes, we are still seeing the aftermath of overprescribing of opioids from the 1990s and early 2000s. But this happened before APRNs in Kentucky even had prescribing privileges for controlled substances. Drug companies perpetuated false marketing to physicians who were prescribing what they were told were non-addictive opioids. By the time we had prescribing privileges, Purdue was already paying back history-making fines and facing criminal charges at the federal and state level. This bill does not eliminate the Kappa CS for new nurse practitioners in their first 4 years of practice, which, by the way, is the longest transition to independent prescribing of any state with prescribing agreements. House Bill 354 does not change the hard stops already in law surrounding Schedule II opioid prescriptions that have been in place since 2006, including prescribing limits set forth in previous legislation. It does not interfere with any employer or hospital contract for employment agreements with an APRN. It does not increase access to opioids. House Bill 354 does not eliminate any regulatory oversight on APRNs, but it does mandate a review of licensure and a designation of good standing by the Kentucky Board of Nursing before the Kappa can be lifted. What else does it do? As you have heard mentioned, in the last 2 years, what we call the real-world trial proved that APRNs were safe and judicious prescribers without Kappa agreements. The General Assembly voted twice during those 22 months to extend executive orders allowing nurse practitioners to prescribe without the Kappa. When compared to the previous 2 years of data, there was no significant difference in the average number of opioid prescriptions written by APRNs without the Kappa in place. This exception was carved out in Senate Bill 25 just 3 weeks ago. House Bill 354 would reinstate the ability for APRNs to continue their same good work they've done during the pandemic beyond the pandemic. Kentucky APRNs stepped up during the pandemic to help treat patients with OUD. When you heard this bill as House Bill 286 in 2020, 408 APRNs held SAMHSA waivers to provide care for medication-assisted treatment in substance use disorder. Today, that number has increased to over 630. That's a minimum of an additional 35,220 patients who can get the help they need to recover from addiction, provided by 222 additional APRNs who can treat 30 patients in their first year, plus an additional 70 each for the original 408. That's 35,220 fewer patients with dirty needles on the street, spreading HIV or hepatitis. That's 35,220 families with the opportunity to reconnect to their loved ones on the road to recovery. 35,220 potential new members of the workforce that Kentucky so desperately needs. House Bill 354 will maintain Kentucky APRNs as master account holders in CASPR, the state prescription drug monitoring program, where prescribing reports will be routinely reviewed and generated. With this bill, CASPR will continue to provide data on prescribers, allowing for analysis, such as the number of physicians in Kentucky, which dropped from 10,848 to 9,797 between 2015 and 2021. And yet they still wrote 1.9 million prescriptions.
Can you give us the highlights of the rest? We got.
Yep.
I know you got someone else to talk, and
okay.
We've got the opponents here to speak.
Okay. Physicians wrote 1.9 million prescriptions for Schedule II opioids in 2021 alone, averaging 198 prescriptions each. This was actually down 22.8% from their previous year. For that same time period, the number of APRNs in Kentucky nearly doubled, and our average number of prescriptions dropped from 152 to 99. That's a drop of 34.9%. But we still have a need for providers in Kentucky, according to the HPSA data. This bill does not add new prescriptions, but as Representative Weber mentioned, it does create a new advisory panel for prescriber oversight, headed up by the Office of Inspector General. What House Bill 354 does is simply this. It allows safe and judicious APRN prescribers in good standing with the Board of Nursing to request permission to eliminate barriers to patient care that has zero scientific evidence of improving outcomes or decreasing the cost of health care in our state. 24 states and 3 U.S. territories have allowed APRNs to practice without this barrier. Let's make Kentucky number 25. And with your permission, Chairman, I would like to introduce my colleague, Dr. Beth Parton, a family nurse practitioner from Columbia, Kentucky, who will share the impact and the importance of House Bill 354 on her patients and her practice in rural Adair County.
Doctor, please use the microphone and be as...
I will. Thank you.
Tell us what we need to know and nothing more, please.
Okay. So thank you, Chairman, and committee members for allowing us to speak today. I've already been introduced, so I will cut that part out. I've practiced in Adair County for the past 30 years where I own a practice. My clinic provided nearly 7,000 visits in the past year. Medicaid and Medicare patients make up 72% of my practice. I provide primary care to children, adults, and elders, and I manage acute chronic health conditions and provide health education and preventive care. I would like to share with you a story about one of my patients that kind of illustrates the type of care that we give. A longtime patient of mine came to me because he was having abdominal pain. I examined him, ordered some tests, and it turned out he had advanced cancer. We discussed his condition, and he declined any treatment because he said he wanted to enjoy the rest of his life without suffering the effects of chemo. So he asked me if I would treat his pain, which I did. He also declined referral to hospice. On subsequent visits, his pain was controlled. He enjoyed spending Christmas with his family and celebrated the birth of a grandson. After New Year's, his pain worsened and he became weak, and he agreed to go to hospice, but only if I would continue to provide care for him. Hospice laws authorize nurse practitioners to be attending providers for hospice patients, so I was able to continue his care, and then my patient died 2 weeks later. The reason I told you the story is because if I had lost my Kappa CS and was not allowed to prescribe the appropriate medication, I would not have been able to provide the necessary care for this patient, the continuity of care, and he would have had to go to a provider whom he did not know, did not have a caring relationship with, and who didn't know him. Nurse practitioners have taken a big step to open a practice. They have invested their own money or taken out significant small business loans. I had to borrow $125,000 to open my practice. It's expensive to purchase medical equipment and pay staff, and it can take up to 3 months before insurance companies begin reimbursing for services. Some insurers have refused to credential and reimburse nurse practitioners unless the collaborating physician is also credentialed with that insurer. And this is another way that the Kappa CS requirement blocks access to care. Nurse practitioners live in fear that they will lose their Kappa CS because the physician withdraws, charges a fee they can't afford, moves out of state, or passes away. And this has happened to nurse practitioners that I know. Losing the Kappa CS means losing the practice. It means patients will not get the care that they need. It means economic loss to the community because the staff that the nurse practitioner has employed lose their jobs. And I can also tell you that if I were to lose my Kappa CS, no local physician would sign an agreement with me. And it's not because they don't like me. We get along really well, in fact. I can call any of them anytime that I need. But I'm competition, and that's pure and simple the reason. House Bill 354 is not just about prescribing scheduled drugs. And you might ask, if a nurse practitioner has authority to prescribe non-scheduled drugs independently, why would they lose their practice? The answer is because to purchase flu vaccine, injectable antibiotics, syringes, and other necessary supplies from medical supply companies or to have your prescriptions for non-scheduled drugs accepted by some out-of-state mail-order pharmacies, you must have a DEA number. Under current law, Kentucky nurse practitioners must have a Kappa CS in order to get a DEA number. When we meet the requirement to have the Kappa CS removed under House Bill 354, we will be able to keep our DEA number and will be able to continue to order the necessary supplies and provide appropriate care for our patients. During the 2 years of the COVID pandemic, nurse practitioners were not required to have a Kappa CS to prescribe. We demonstrated that we were prudent prescribers of controlled substances. We are not afraid to have our prescribing record examined by a review panel as described in the committee substitute. Passage of House Bill 354 will allow nurse practitioners to improve access to quality care. Studies from states that grant nurse practitioners authority to practice to the full extent of their education and training have shown that nurse practitioners do establish practices in rural and underserved areas, providing much needed care. Please vote yes for House Bill 354.
Thank you. Representative Minter, I see you're there. As a courtesy, I'd like to give you a couple minutes to speak, but don't feel compelled to take them.
I absolutely won't.
Thank you.
But we have a large bipartisan number of co-sponsors on this bill, and I would urge that the committee move this bill forward to the full House.
Thank you. Representative Miller has a question for this
Actually,
panel.
she answered my question, so
There you
I'll
go.
keep my statement very, very brief.
Yes, sir.
And I've said in this committee before, APRNs are the general practitioners of when I was young. It was like in the 50s and 60s. We had general practitioners. A lot of them made house calls. If you want access, quick access to health care, today it's APRNs you look to. Thank you.
Thank you. Representative Miller, were those offices all in black and white? Okay.
And he drove a black and white VW Beetle.
Thank you. Any other questions for this panel? Representative Moser.
Thank you, Mr. Chair. Thank you for your testimony today. I have a couple of questions. I know that you ran through the bill, and I think I just want the committee and all who are watching to understand specifically what this does. So can you explain exactly what lifting the Kappa CS does? We heard about the expansion of practice. What specifically will this allow APRNs to do?
It's not an expansion of practice because this is already within our practice scope. The thing that this does is eliminates the agreement. It doesn't change anything else. The nurse practitioners who are new will still have 4 years collaborating with the physician before they will be able to apply for the good standing review by the board. And then if they are deemed in good standing, then that agreement with the physician would go away, but they would continue prescribing under the same rules and the same statutory limits that are already in place.
If I may, Mr. Chair, is this an option or is this an automatic roll-off of the Kappa CS after 4 years?
No, it is not automatic. It is a process. They will have to apply to the board, and the board will have to grant that permission after the review.
Okay, so back to my first question. What specifically does lifting the Kappa CS do?
I think I spoke to that in my testimony. If you have to have a DEA number in order to order flu vaccine and certain supplies for your practice. You have to have a DEA number for a lot of prescriptions, out-of-state pharmacies for non-scheduled drugs when you're filling those prescriptions for patients.
But you can have that in a collaborative agreement, correct?
You can, but
yeah.
You have to find somebody to sign that agreement, and that's not always easy. Plus, if something happens to the physician or the physician withdraws, you're suddenly there with a practice and not able to do some of the things that you need to do.
That's another good point, actually, because if something happened to the physician or the physician's license, the nurse practitioner is put in jeopardy, even if she's not in the same town, in the same city, or just by being attached to a collaborator. If the collaborator loses their license or has an accident or is suddenly unavailable or dies, that nurse practitioner practice is then put in at risk.
Well, I mean, I think that there are ways to strengthen the collaborative agreement if that would be an option that anyone would agree to, but that has not been the case. Will this help recruit, do you think, physicians to rural areas and some of the underserved areas? I mean, it looks to me that eliminating the Kappa CS will increase competition, as you alluded to. So I'm concerned about the lack of physicians in underserved areas as well. And I just don't see that this will be very encouraging to individuals who are in medical school and are looking to provide primary care. That's one of my concerns. But I guess I'll just go ahead and answer my first question. CS stands for controlled substances. So that's what this is about, right? I mean,
That's part of it.
Okay. All right. Thank you.
Any further questions for this panel? Thank you all very much. We have Corey Meadows, who's assigned to speak on the matter. Corey, if you'd come on down. Please turn on your microphone and introduce yourself for the record.
Good morning, Mr. Chair and committee members. For the record, my name is Corey Meadows. I am Deputy Executive Vice President and Director of Advocacy for the Kentucky Medical Association, and we appreciate the opportunity in the few minutes that we do have, and I'll try to keep my comments brief regarding this issue. I want to just state at the outset a couple of things. Number one, the Kentucky Medical Association has been, and will always be concerned about the elimination of the Kappa CS. I want to address a couple of things that came out of testimony first. We certainly appreciate any attempt that legislators have got involved in this to suggest potential changes to try to make this bill stronger. The one question that comes to our mind about putting in place this panel that has been suggested, despite well-intended, is this question: shouldn't the board already be doing those things? And I think that's a question for legislators to consider when they look at the regulatory boards and they look at how they manage the prescribing patterns and behaviors of their licensees, about how are they regulating that, how are they overseeing that, and why is it necessary to put in place another panel to do what their board should already be doing. I'm not suggesting that there is a problem, but that is a question to be asked before we put in place another set of bureaucracy to take a look at that. The other thing I want to point out is that I think there were some references to Casper numbers showing consistently that their numbers are going down. This is clear. We have a real disagreement about what Casper numbers actually say, because we have Casper numbers that show that they are consistently up, way up, over the course of a lot of years. And so maybe a starting point for both groups is to get together and compare their numbers and see how we're analyzing those numbers, because we've been very consistent in using raw Casper numbers since 2011, which is a year prior to House Bill 1. House Bill 1, for those of you who weren't here, was what was commonly referred to as the pill mill bill. A lot of restrictions were put in place on every provider in how they prescribe controlled substances because of the opioid use disorder issue that we face. And so that's why we picked a year prior to 2012 to see whose numbers were going up and whose numbers were going down. And consistently, there's been one group that has been up, while dentists and physicians have come down. And so we need to have a very serious look at what numbers we're looking at, how we're using those numbers, how we're analyzing those numbers. But I will say this, is that we cannot support anything that looks to eliminate the Kappa CS. You heard a lot about access. I challenge committee members to take a hard look at the legislation and look in there to see where are there provisions to address high blood pressure, where are there provisions to deal with obesity, where are there provisions to deal with a lot of the chronic conditions that we face as a population here in Kentucky. I'll give you a preview. You won't find it. because this bill is exclusively about one thing, and that is controlled substances. And that concerns us from a public safety point. I know there's a lot, historically it's a turf war, right? Competition, doctors are worried. One of the reasons you can't see your primary care physician as quickly as what you'd like is because there is a lot of business to go around right now. I haven't heard one of my members approach me and say, I'm opposed to this bill because it's putting me out of business. I just haven't heard that. So there's enough business to go around. It's not a turf war. It is a public health issue, and the CDC numbers bear that out. Kentucky is now ranked 3rd in the nation for overdose deaths. It's up 55% in our state. And I want to make something very clear here because it was referenced, and I think attention was given to it in the previous testimony. We're not blaming nurse practitioners for that increase in those overdose deaths. It's a nice talking point, but that's not what we're doing. What we're doing, and Dr. Fletcher is correct, is that a lot of this is synthetic opioids coming from out of the country. We acknowledge that. But what message do we send at the height of our opioid epidemic to where we're looking at a bill and removing what can be a legitimate check and balance to control the flow of these very serious medications when we still are looking at numbers at that degree? We think it runs counter to what the General Assembly has done for the last 10 years in passing legislation trying to deal with the opioid use disorder that we face. Numerous pieces of legislation have been passed to fix that problem, to rectify what we're seeing. And so we think that sends the wrong message. And we do want to take up the executive order. First of all, it wasn't extended the last time. It was extended before. It was put in place. And we see that more as not a permission to do these things. It was a 2-year opportunity, that we believe that they missed because 2 things were apparent. Our numbers say that their prescriptions went up during that time, during a time when they actually probably saw less patients and offices were closed because of COVID. So the numbers naturally should have been down, but they went up. The other thing that was recently testified to in another committee by the executive director of the Board of Nursing, the Kentucky Nurses Association, is that if you eliminate the cap of CS, we will be welcoming 2,000 nurse practitioners home to Kentucky. Well, for 2 years, that opportunity also was there. Did we see a mass influx or relocation of nurse practitioners to Kentucky? No. So we believe that was an opportunity had and an opportunity missed. And I'll end with this. The cap of CS is not a barrier. It just isn't. Because while we didn't see 2,000 nurses come home to Kentucky, we have seen a very steady increase of nurse practitioners practicing in Kentucky. And I'll be the first to say that's a good thing. That's a very good thing. And they've done it with the cap of CS. They're not decreasing in numbers. This is not a barrier. They can currently locate anywhere they want to within the state of Kentucky to set up a practice. They're right. They're independent except with respect to the cap of CS. So they can locate there. They can open up a practice. They can treat. They can diagnose. They can prescribe. But as we've shown you through some geo mapping that hopefully you received yesterday, that nurse practitioners will locate, largely like a lot of other provider groups, in the metropolitan areas. And so what does this mean? It means this: whether it's APRNs, PAs, dentists, pharmacists, OTs, ATs, PTs, every other group, what it means is that this effort over the last 20 to 25 years to expand scope, to fix the access problem, has not worked. It's a failed policy that's been tried and has failed. Quite simply, I'll leave you with this. We cannot scope of practice our way out of the access issues. But there are constructive solutions. And I'll point to House Bill 573. Representative Mosier has filed that. It's about a loan forgiveness program that we've been working with her on before the session even started. And here's who it benefits. You may be thinking, well, this is going to help physicians forgive their loans. Physicians are a part of it, but so are nurse practitioners, so are PAs, so are dentists, and a whole host of other healthcare providers that we wanted to keep in there to truly try to solve the access problem. This is not the solution. Thank you, Mr. Chair.
Absolutely. Representative Bratcher, do you have a question for?
Yes, I do. First, say hello to Whitney. She's one of my favorite people to ever deal with. So, Mr. Meadows, ever since this issue has come up, I've always been confused with the collaborative agreement. What skin in the game does the doctor have when he or she goes into that agreement?
So what it's really intended to do, it's really intended to be a two-way street. It's not supposed to be punitive to the nurse practitioner. We have always said, because we've heard from our members, that the Kappa CS can be as beneficial to the physician as it is the nurse practitioner. Notice we don't say supervision agreement. We say collaborative agreement. It's a true collaboration. So what it's meant to do is it's meant to talk, discuss, if there are questions, establish maybe some parameters around that. It really
is that a
meant to be
requirement, though?
In Kentucky, yes, it is a requirement that they have the Kappa CS in place when they prescribe controlled substances.
No, I mean, is it a requirement that they work together?
The Board of Medical Licensure lays out in the board opinion very good guidance on the way a collaborative agreement should be handled. So yes, physicians should be doing it that way. Yes.
Is there any liability to the doctor?
Absolutely. Anytime a physician either supervises or collaborates, there's going to be massive liability. And that's one thing that we've noticed when there have been issues, whether it's testosterone or other controlled substances, and there's lawsuits filed. Oftentimes the nurse practitioner is brought in, but they also target directly at the physician because, they're brought into it because they're a part of that collaborative agreement. Now, one thing you may be referencing is that you hear a lot about, well, they charge a lot for these collaborative agreements, and it's extortion. I'll say this about some of the comments that were made about, if someone dies and we lose our collaborative agreement or what we're being charged. We have consistently asked for that data, and we have consistently not seen it. So we've kind of taken at face value that these problems exist, and we've tried in the past to work around those. But to be honest with you, we've never seen the data showing where massive amounts of nurse practitioners have lost their collaborator and their practices have shut down. We just don't know whether that exists or not.
Is there a cap on how much they can charge for a collaborator?
There isn't, Representative Bratcher, and that's been discussed because at face value, we have said if there is extortion going on by physicians, that needs to be addressed.
Could there be extortion going on?
Again, I haven't seen numbers showing that these wild amounts that are being charged. I would suspect that if there is, and I say if because I can't verify that it's rare, it's isolated, and we would say again that needs to be dealt with by the respective boards. But that's why we think a stronger collaborative agreement is necessary, not one that gets phased out. And the other thing I'll point out about the bill is that they talk about, a new nurse practitioner would have 4 years. Well, notice in the bill they also eliminate the 1-year moratorium for new nurse practitioners. Notice that language is struck out of the bill. Currently, they have to wait a year before they can do that. That language has been struck, so a new nurse practitioner could come out and immediately start prescribing controlled substances with a Kappa CS. Physicians don't even have that ability. So why are we setting a different standard for nurse practitioners?
Representative Gentry.
Thank you, Mr. Chair. Thank you, Corey, for being here. And just a very simple question. Do you feel APRNs are medically qualified to prescribe controlled substances?
We know that they receive some education and training in that area, but we do feel like that it is value added when it is in collaboration with a physician who also has an extensive amount of education and training as well. We think that is a partnership that works, especially in an area as serious as controlled substances. Again, the bill is exclusively on that subject. And so we feel like that partnership is what is required to make sure it's in check. No. Did they create the problem? No. Do we want to exacerbate it or add to it? Absolutely not. And that's what we think this actually does.
And I appreciate that answer. And I'll tell you, I'm certainly not a medical professional. But I will share with you my experiences with opioids. I'm an amputee, and I have some chronic pain issues, nerve pain issues. Luckily for me, they're minor, but I used to played competitive disabled golf, traveled around the country. You know, my experiences in the 1990s, all the amputees, brachial plexus type injuries, they all had something in their golf bags. Pill bottles that were given to us for chronic pain. And I've seen a lot of people's lives destroyed. And your profession doesn't have a good track history on that. And I just want to point that out. I know this is a very, very delicate issue. I know the problems that have been created in every community across this country. So I appreciate your testimony today, and I appreciate the testimony of the people before you as well, and I will leave it at that. Thank you, Mr. Chair.
Thank you. Last is Representative Banta, then we're going to vote.
I've been on this bill now as a co-sponsor for a few years, and I only have an APRN. I don't have a doctor, and I'm very happy, but I don't even ask for an aspirin. So, but my question is, when I speak to people that are involved in this, I'm like, why can't you guys meet and come together and talk about this so every year we aren't battling this out? And the answer I got is that doctors aren't really willing to meet with them. So is there ever a way you guys can all get together and duke it out?
If there is one thing, I'm generally pretty diplomatic in my responses by design. But this is one that I will certainly push, not at your question, it's a valid question. I will push back as hard as I possibly can on anyone who says that KMA has ever turned down a meeting, been willing to discuss, or offer solutions. In fact, when this was a Senate bill last year, we proposed two different options. Number one, get rid of the collaborative agreement and go under the KBML and be regulated like the physicians are. Let's get this all under one board. Rejected. Option two, let's strengthen the collaborative agreement and have a list of safeguards that we can put in place. And if we do that, we'll phase it out after a certain number of years. We didn't like 4. We suggested 8. Is that negotiable? Yes. As long as it's comprehensive safeguards that makes sure that while that cap of CS is in place, it is meaningful and not a worthless piece of paper like the nurse practitioners have consistently said it is. So put some teeth to it, and then after a number of years, it can phase out. So we're willing to meet. We've always been willing to meet, and I want to tell you all, any suggestion otherwise is just disingenuous.
We have a motion and a second. Please call the roll.
Representative Banta.
Yes.
Representative Bratcher.
Yes.
Representative Birch. Representative Flannery.
Yes.
Representative Gentry.
Explain my vote, please.
Yes, sir.
As a 57-year-old amputee and advocate for personal health and fitness, I cast my yes vote today on behalf of my personal APRN, Oliver Olson, who has helped me be healthy and fit for my age, and I have complete confidence that he, with collaboration from me, can prescribe me what he thinks I need. Thank you.
Representative Herron.
Yes.
Representative Huff.
Yes.
Representative Cook.
No.
Representative Massey.
Yes.
Representative McCoy.
Yes.
Representative Meredith. Representative Miller.
Yes, and explain my vote.
Yes.
As a co-sponsor, I just want to appeal to everyone listening and watching that we don't have enough primary care physicians to take care of Kentuckians. Kentucky is 40th in primary care physicians per capita. Ohio is 13th. West Virginia is 14th. Tennessee is 28th. We're 40th. We need this. Thank you. I vote yes.
Representative Moser.
Explain my vote, please.
Yes.
I am a no. I am concerned that this will further erode the partnership and the collaboration that we see now in patient care, and I am greatly concerned that this will further diminish the number of physicians that we have in the state. I am a nurse. I completely understand the value of our great nurses, and I appreciate all of the service. But I really am concerned, about a lot of things. I've been part of this conversation for a long time, and I do understand that there have been some offers to really make the collaborative agreement better, stronger, and protect nurses. I'm just concerned that there really hasn't been a whole lot of compromise. And on the issue of nurses coming back to Kentucky if the Kappa CS is lifted, it's a bit of a red flag to think that nurses are coming back specifically to prescribe controlled substances. But anyway, I can't be a yes today. I will reserve the right to change my mind on the floor if some changes are made. And thank you.
Representative Palumbo. Representative Pratt.
Yes.
Representative Santoro.
No.
Representative Timoney. Representative Westrom.
I'd like to explain my vote.
Yes.
I've been acutely aware for the last 24 years how vast our medically underserved areas are in this state. And I thank our ARPNs who are filling those areas to meet the needs of the medically underserved. Thank you.
Chairman Koenig.
No. Motion passes. That same shall pass on the House floor. There is a title amendment. Chair will entertain a motion to approve such. A motion. Is there a second? There's a second. All in favor signify by saying aye. All opposed? Motion carries. Congratulations. Representative Weber. Representative Mosier, would you like to record a vote on House Bill 97?
Yes, I would like to record a yes vote on House Bill 97.
Thank you. Having come to the end of the agenda, next week we will start meeting in room 169. So don't get lost. And we'll probably meet next week, and keep your ears open for a possible special meeting. We are adjourned. Thank you.